Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Cara Hope Rockwell.
And we want to thank everyone for tuning in. If you haven't already, please like and subscribe to the podcast so you can stay abreast of all of our new episodes.
And if there are any guests you'd like us to have on or any topics you want us to cover, you can let us know at sgmc.org/podcast.
All right, so today we are here with Tommy Hobby, DO, Internal Medicine at our SGMC Valdosta Medical Clinic.
Thanks for having me.
Yeah, so Dr. Hobby, what brings you in today?
Hopefully talk about primary care and hospice and palliative care.
All right, well, tell us a little bit about your background, kind of your journey to where you are today. So,
I'm originally from Valdosta, and so I went to Lowndes High School and go Vikings. And so, grew up in the sort of in the medical home. My father's a retired interventional radiologist, so I enjoyed going to the hospital with him and watching him, come up at the hospital and take care of patients. And so, just had an interest in doing medicine. And when I went to medical school, really liked primary care. I enjoyed taking care of primary care patients, and specifically enjoyed taking care of older patients, and that's what sort of led me into internal medicine.
Okay. Did you always know you wanted to be a doctor growing up?
I had it just living in the house with my watching my dad. I always kind of said I was going to be a doctor, and so and just kept at it and went through college and got into medical school, and everything worked out that way.
All right. And so how long have you been practicing now?
I've been back in Valdosta for 25 years.
Okay.
So went away, went to Valdosta State, went away for medical school, and did my training up in Chattanooga, Tennessee, and then came back in 2000 and been here ever since.
All right. Well, tell us a little bit about just your bread and butter, your primary care physician patients. Why should somebody have a primary care physician?
Well, the majority of patients that I see are 18 and older, and the majority of those are pretty much 65 and older. I see diabetes, heart disease, high cholesterol, a lot of arthritis. Typically I hear a lot of arthritis complaints, and recently a lot more memory and dementia patients. Our patient population, the medical field's doing a great job of keeping people alive, older, and so the older patients get, the more we see a little bit more of dementia. So seeing a lot more of that recently.
That's interesting because we were just recording an episode with our new orthopedic surgeons, and they were talking about the arthritis issues leading to hip replacements and knee replacements, and that being a bigger issue. So.
Yeah, as patients are getting older, in the medical field, we do a great job. We've got a lot of advances in heart disease. I mean, we're doing aortic valve fixing in patients that we've never done in 90-year-olds, and so these patients, we're keeping them alive a lot longer. But unfortunately, when it comes to dementia, there's not a lot of prevention type tools that we have. So as these patients get older, you see more dementia, see more arthritis.
I was just talking to my mother last night on the phone, and both of her parents, one has Alzheimer's and the other has dementia. So it's interesting that you say that, but we are definitely seeing
and a lot of
that.
New advances in dementia, and through our neurologist of doing different types of scans, doing screening, trying to find out if you have the gene for dementia. So a lot better treatment options recently. So a lot of new things in the dementia field.
Yeah, I was in a neurology meeting yesterday, and they were talking about like infusion therapy that they're also offering.
Yeah, amyloid deposition is the new buzzword, and checking, doing PET amyloid scans, PET CTs, and finding those early. And I have patients that have been doing infusions and actually seeing improvement in their memory. So a lot of good stuff.
How do you typically catch that kind of thing from a primary care visit per se?
Well, I try to encourage my patients to obviously keep their appointments. Regular appointments go a long way. Seeing these patients earlier, establishing with a primary care. I think females do a really good job with that because they're going and seeing their gynecologist. They're doing lab work. Males typically do a horrible job at that.
Yeah.
They only come in when they have problems. And so Well, I try to encourage, at least by 40, start seeing your primary care on a regular basis. And so you screen for these things. We do a lot of screening when it comes to patients when they hit 65 through a lot of the what we call annual Medicare wellness visits. We do simple tools like drawing a clock, getting them to remember 3 words. So we're doing a lot of dementia screening. And the other big thing is if it's in your family, so knowing your genetics and doing these screening tests early really help out with earlier treatment and better outcomes.
I'm sure there's a big family component to that too, of like maybe you're noticing something in your aging parent or your grandparent or whatever, some behaviors that are a little bit different, and encouraging them to go see you, go to the doctor.
It's the, daughters and sons that bring in their parents and say, we've noticed this. A lot of patients as they get older, they feel embarrassed about coming and talking to their doctor that they're having memory problems. And again, females do a lot better job of talking with their doctors about symptoms than the males do. And so it's good to come in early.
It's funny you said that, because my husband turned 40 this past August, and I was joking with him yesterday morning. I was like, I think you're getting close to that age now for a colonoscopy. So,
and they, we used to start doing colonoscopies at 50. They just moved it to 45.
Yep.
And then if you've got a family history of colon cancer, we start them even earlier. We start them 10 years before that. Your loved one is mom, dad, brother, or sister. Have colon cancer, you start at 10 years before they had their diagnosis of cancer. So we're doing them a lot earlier.
Well, I got to start planting the seed now, because it'll take me 5 years to convince him to get, to get into the doctor.
Well, I love, we do have some positive outcomes. So when you hear those positive outcomes of a patient that's not having symptoms, come in, do a colonoscopy, they have a polyp that was sort of a precancerous polyp, and you've basically prevented them from having colon cancer. Those are good stories you can tell patients.
And we
had
tell
your husband.
Yeah, and we had that conversation yesterday too with breast cancer screening, that we knew someone that we had encouraged. During October, they typically high awareness is brought to mammograms, and somebody found something, and it's just as scary as that can be. It's a lot scarier if you had waited 10 years and then got that scan.
Right.
The treatment is so much better and more productive. So
early detection.
Yeah.
In all cancers. Mm-hmm. Absolutely.
So what about, so you said primarily it seemed to me that like you had an older population of patients. How do you encourage that 18-year-old to 40 to go ahead and establish a primary care provider?
Again, like we talked about, when females are going through gynecology, they're doing a lot better job. We typically get those females when they have a problem like hypertension or high cholesterol and need treatment. And just encouraging patients to at least come in once a year, get lab work, knowing their genetics, screening them for smoking, screening them for blood pressure issues, and again, starting those screenings early. It's recommended at age 40 to start doing labs. We have some patients that we start them at, in their 20, 21, even 18 if they have a strong family history of heart disease. I have a strong family history of heart disease, and so I do a lot of, early detection labs and, trying to keep healthy, trying to eat right, one of the hardest things to do, and keeping my, weight in a good status. I think a lot of patients that I deal with on a every day is, Dr. Hobby, how can I lose weight? I'm having a hard time. It's a lot easier to get fit at an earlier age until you start at age 60. It's hard. And again, females have a lot harder time with doing that, after menopause. So earlier you start, the better you'll be.
What do you think about like the 23andMe and genetic testing? And do you ever have patients come in and say, hey, this test shows that I have an increased risk of XYZ?
I think a lot of that, everything helps. So if you're going and doing the, genetic testing and you're finding that you're at risk for this, so it puts awareness to this, and it makes patients come in earlier, start doing testing. A lot of that is reassurance. Hey, just because you've tested positive through this 23andMe doesn't mean you're going to definitely get, this disease. You're at risk, and let's do some screening tests to prevent those in early detection.
I find that stuff so fascinating.
Yeah, you may find out you have a relative you didn't know about, though, right? That's kind of the thing that everybody's figuring out these days with that.
That's right. And with today's Google Doc, we get a lot of that of patients coming in. Hey, I Googled, I've got stomach pains, and I've Googled that I have pancreatic cancer. And so a lot of that. And then when you get them in, then you can start doing these screening tests and preventative tests and reassuring them that they don't have pancreatic cancer.
Right.
Yes. So I had an idea while you were talking and thinking specifically for the male population that does not go to the doctor. I think it's probably going to be the mothers that need to keep that doctor visit going after they turn 18. So the moms need to be like, all right, you need to go ahead and get a primary care. And
You're encouraging helicopter
best.
Moms?
No, it's not helicopter, but you got to start that habit, that healthy habit, and if you do it every year, it's not like as weird, it's not such a,
whatever
you're
works.
more comfortable with it.
Yeah.
So I think the moms, we can put that one on the moms to try to get their sons
my son
to.
listens to his mom a little bit. My 17-year-old son listens to his mom a lot more than he listens to me. So,
See? Okay. That's going to be my next push. I'll work on that. So you also specialize in hospice and palliative care. And there's a lot of misconceptions in that realm. So
Absolutely.
just give us a brief overview to start us off on hospice and palliative care, what the differences are.
So 2009, the position for medical director came available through Hospice of South Georgia and Langdale Hospice House. And I took that role, one of the best decisions I made. I really enjoy taking care of hospice patients. They built the Langdale Hospice House sometime around 2007. And our hospice organization has grown tremendously. We service about an average of about 140 patients a day. At the outpatient setting, so in their home or in a nursing care facility. We cover 8 counties, around Lowndes County. And then we also have the Langdale Hospice House, and we have 15 beds that provide different levels of care of inpatient and respite care and residential. I've been the medical director of that. In 2012, Tana Macera and I got together and decided to create an inpatient palliative care program. Started out, and we were only allowed to see patients, in the intensive care unit at that time. Now we go over to Smith. We see patients down in the emergency room, and our service has grown. We have 2 nurse practitioners now and a nursing director that manages patients, so definitely grown. The outpatient palliative care services run by Emily DeCesar. She started out having maybe 4 or 5 patients. She has a census of around 40 patients that she sees. Y'all had a meeting with Eli, and he does all our outpatient hospice and the inpatient part of the hospice house. So huge organization, has grown.
And remind me again, because it is confusing if you don't live that world every day, what is the difference between hospice and palliative care?
Yeah, I get this question all the time. I think the misconception that palliative care is hospice and hospice is palliative care, both of them, basically deal with the care of a patient with serious illness and help improve quality of life. The difference of it depends on their eligibility and the care that they're going to receive. So with palliative care, it's the care of a patient that has a serious illness but is receiving curative care. The difference with hospice would mean that patient that is receiving care with a serious illness but technically has less than 6 months to live. A lot of overlap. When I'll give an example. So if you have a patient that is diagnosed with cancer, immediately that patient is a palliative care patient. So if palliative care is consulted, they help out and work along with their oncologist. They continue to receive curative treatment. And we help out with emotional support. We help out with advanced care planning. And then when that patient, if they have a uncurable cancer and they get to the point where there's no curative treatment and they don't want to come back to the hospital or go to the emergency room, then that's the perfect hospice patient. Then we come in, provide services, whether it's emotional support, spiritual support. We do a lot of family teaching on caregiving. So if you've got a patient or loved one or a friend that you're dealing with, everybody's new in how to take care of this patient. So we sit down from social working, from nursing, from pastoral care. We provide aides in the house that can do bathing and then medical needs, so medical equipment. So I think the misconception is when patients are, when you hear the word hospice, it means you're giving up. But when we admit these patients into hospice, we sit down as a team with them. The intake nurses meet with them, meet with the families, and offer so much services, and then sort of guide them on how their care is, and it just ends up being a good thing.
Yeah, it's just additional support to
Absolutely.
deal with the process at hand. I was able to attend the South Georgia Alliance, Health Alliance board meeting this past week, which includes the Hospice of South Georgia and Langdale Hospice House and our Langdale Place. But the entire room was in tears by the time Amanda, who's the director over there, got done with
Absolutely.
her report, because it is just such impactful work that happens over there. And it was emotional, but it was a good emotional because it was what they were offering for those families and what they were doing. It was just so impressive.
And I think the misconception also with with hospice is, all right, you're going to go home, you're going to die. And we get this, hey, you're going to stop all our medicines, or if we have an infection, you're not going to treat that. So one of the first things that we do is sit down and talk with patients about trying to reduce the amount of medication. So if they have an abnormal heart rate, and we don't take them off of their blood pressure medicines, we don't take them off of their diabetes medicines. So we continue all those medicines, and those medicines typically come under the hospice benefit. So we start covering these medications. Obviously, primary prevention medicines, like if a patient has high cholesterol, we'll typically stop cholesterol medicines for long-term use. But if they're on thyroid medicines, we continue those things. The other misconception is, hey, they're going to go home, they're going to get morphine, and they're going to die. And so one of the things that we do is get pain under control, get symptoms under control. So again, going through their medications, simplifying medications, and seeing sometimes even improvement. Some of the best patients that we have is patients that we used to just kind of all see just cancer patients. But now we see heart failure patients. We see, again, we talked about dementia. The dementia patients that we have increased over the last 10 years. Just since I've been doing it, the majority of patients were all cancer. Now we see, again, dementia, heart failure, and so, chronic illnesses that are admitted. And now, our cancer patients are probably only about, 25 to 30% of our patients that we take care of.
Maybe that's just through increased awareness too of what the service is
Absolutely.
and how it works. And then we also launched recently a dementia or Alzheimer's support group, caregiver support group, maybe. So if you do know someone that, a family member that is experiencing that and you're a caregiver, that is another resource that you can, it's a free support group that.
Yeah, any of those support groups, I think people are initially scared about going to them, and then they find out that they get answers because they see people that are going through the exact same things that they're going through, and it's always a good thing.
And it's more common than you think. You know, oftentimes when you get those diagnoses or, something just dramatic in your life, you're alone.
alone.
Yeah. So being connected with people that are in similar
and these
situations.
families that we go in and try to, give support to, like I said, they're new to this. And then when you start teaching them how to caregive, they do better. You know, the patients do better, the families do better, and they start managing the patients at home. And I would say, never do I hear any of the families saying, I wish that we had never called in hospice. It's constant. We get the same sort of comments back from the families. We should have done hospice a long time ago.
Yeah. It doesn't hurt to ever go ahead and get more information, request education about it.
And they always have the option, if we go in, meet with the family, and they hear our intake nurses talked about the service, they can always say no. If something changes, if their symptoms start getting better, we do have patients that come into hospice and then graduate from hospice. So they were receiving treatment, and sometimes the treatment is worse than the disease, and so they cut back or stop that curative treatment. They start improving. They graduate from hospice, and then we're available if they need us, in the future. So we do see that. I would say we do have a lot of patients that we see that maybe go to a tertiary center, so they're have cancer or at the end stage of their treatment. It's always you want to have a second opinion. There's no such thing as a bad second opinion. They'll end up going and getting a second opinion at a tertiary center at, where MD Anderson or Moffitt, and then we'll bring them back home. They'll be able to go into their home where they can be around family and friends, and that is some of the best work we do.
Absolutely. 3 of my grandparents have been on hospice, and so definitely has a special place in my family's heart.
Yeah, and we see if we have a spouse that's on hospice, and typically what we'll see is if their wife died 3 years ago, then we'll see the husband at a later date, and that's always sort of that we know that we're doing a great job when the
Choose to utilize the same service.
Absolutely.
Dr. Hobby, you've been serving here in Valdosta in our community for a while. What would you say is the biggest change in healthcare that you've noticed, in any kind of trends or technology, or what's been the most impactful
Technology would
thing?
be the biggest thing. When I started in 2000, we were using paper charts. As the senior, Dr. Brady and I are the senior doctors in our group now, and sometimes
we call that seasoned,
that's
not
right.
seniors.
Seasoned doctors
That's
in
what
there.
it's like.
We sometimes I wish I could go back to a paper chart. Electronic health records have definitely changed the way we practice medicine. Sometimes I feel like I'm just kind of staring at a computer, sometimes pressing buttons, and the patient's kind of looking at me. And so I typically try to have that face-to-face time and then go to my computer. So I would say that's the biggest changes. But, what is a positive, what comes with that? Reminding me about certain types of preventative tests that be done. I have a little column over there that tells me, hey, don't forget about the flu shot. So definitely improving the practice of medicine. And it's done good from that.
Do you think that patients are more active in their health care?
Absolutely.
Now?
Internet has changed the way. I mean, you can go on and chat GPT and tell them, hey, I've got this, I've got that. The majority of the time, they typically will give you a diagnosis when it's not the older patients, it's the younger patients. They'll come in and let you know what's wrong with them ahead of time. And so, and it helps out. And sometimes it can
Lead you astray.
lead you astray. So you just kind of have to, stick with your instinct and your knowledge that you have.
Yeah.
But I would say that was the biggest change, is the Google.
We had Dr. Google, but now we have Dr. AI.
Right,
Just
yeah,
ask
it's a whole other
ChatGPT.
element, which I was on a call with our Epic team recently, and they were talking about a new feature that will be released soon, will be within the MyChart and your Epic platform. You'll be able to utilize the AI for the diagnose, or for an overview, because most people just copy it out of their MyChart into like a ChatGPT.
Correct.
So they'll be able to do it within the My Chart, want to keep it secure and to have a more medically sound.
Yeah, I mean, I know that the current system that
Feedback.
we have, you know, I can walk in the room. I really don't have to press anything. It'll listen to what I'm saying. That scares me a little bit, just being an older guy.
Documentation,
Right,
yeah.
and so I think I'm going to leave that to the younger guys in the group to test that out. But because I typically, I mean, mine's a lot. I think a lot of my visit is a social visit. I enjoy talking with patients, and I tend to get a little sidetracked. And so, but I think AI is going to be a positive thing.
Yeah, well, you're probably really good at it. I mean, you're probably so skilled now at documentation.
It's gotten
got
easy
that.
for me.
Yeah. It is interesting to see how all that
Absolutely.
and now you can get your lab results and everything like in the blink of an eye.
Immediately.
Before I get them,
Before you
patients
get 'em,
get them
yeah.
and call me and say, "Hey, what's wrong with my monocytes?" And so
Start looking that up.
a lot of clarification.
Yeah, for sure. I think that's the biggest one is the lab results. And if it's just a little bit outside of that normal range, everybody goes crazy. But there is some room for it to be outside of that is
Sure.
what I've found out from my doctor when I've done the
Absolutely.
same thing.
Well, I think that's
Okay.
about all
You
that
got
we
anything
have.
else you want to share with us today?
I appreciate y'all having me and bringing awareness to hospice and palliative care. One of the best things I do in the day.
Well, thank you for your dedication to healthcare in our community and to the service to our patients. So we appreciate you.
Absolutely. Thank you. Enjoyed it.